Good afternoon and welcome everybody. Welcome after this lunch and the post-lunch session on colonic surgery. So the first video lecture is going to be given by Dr. Manas Roy, and he is going to present on laparoscopic sigmoid colectomy.
Thank you, sir. Thank you, ISG, for this opportunity. Special thanks to Dr. Bhartiya. I started my career in this city as his deputy, and can we go back, please? That's me. Thanks to Amrit, my colleague from Tata Medical Center, who helped making the video. Thank you. So, instead of left hemicolectomy, I'll doing a left laparoscopic sigmoid standard ports. The first thing is the patient should be head low, right side low, and the bowel should be in the upper quadrant. You need a good nurse to lift the sigmoid. I'm a sort of a hooker. It's cheap, more reliable, and by graduating from laparoscopic cholecystectomy to colon, I think hook becomes your best friend. It slows you down, So your left hand has to be very strong. Unless the tissue is under traction, the hook doesn't cut. If you do not want to get lost, best is to go down the TME plane. That's usually, you will never get lost. This edema is due to the tumor. Mobilizing the rectum helps during the stapling too, and decreases the tension on the anastomosis. I don't put any gauge piece, I just do it slowly. One of the benefits of robot is that the camera is still, so you need a good assistant. That's the IMA. Yesterday in the bursary, Dr. Sitaram told to keep things simple, right, Rajesh? At this stage, you have to separate from gerotas, but that can be done later. The gerota fat is little more orangish as compared to the mesocolic fat. So at this stage, I take the ligature. Not that I own the shares of Medtronic, but IMA and IMV are just 4 millimeter, so I don't put clips or just. Had this been a low anti-resection, I would have gone little more cranial towards the pancreas to take the IMV, but this is a straightforward sigmoid. So That's a big mass. Now, while going medial to lateral, I often get lost. So I go to the left side, I do a little lateral to medial on the pelvic brim. Be careful, the left ureter will be hiding somewhere. This window is an extremely useful maneuver. Now the specimen flipped back to the left side. That window is extremely sort of a guide for your subsequent dissection. I picked this video for a reason, a mistake I made, I'll show you. Now, if you believe in the complete mesocoelic excision, now going laterally, if there is no traction, ligature should be used or harmonic. Now, here it is. Separating the mesocolon from the gerotas, and this is where I made a little mistake. I went deep underneath the gerotas. I'm trying to bring it down, and lack of traction, so I'm using the ligature. See, the kidney is exposed. That shouldn't be the case. You should not expose the kidney. But often easier said than done. So this is the embryonic plane, which by definition should be avascular. So now I'm going down the left side. The patient is right low, so you should do the left last, because otherwise the specimen will by gravity fall towards you. You often get carried away into the pelvis, which is in a way good because that helps the stapling. At this stage, the ligature is must, because the veins and arteries you cannot take with the hook. This is a sigmoid colectomy, so uterus I didn't hitch up. Ideally 160 should suffice, but in this patient we had to use a second 45. Small infraumbilical or Fannin style, Alex's bag. Rest is very simple, as you know. The perineal surgeon, you have to help him up, down, right, left. And now if we clean the proximal colon for the anvil, it makes sense to clean the distal stump of the fat. I'm sure it's a standard practice. Wait till the orange line comes through. I'm just feeling the entire circle. I'm aware there are special graspers for this step, but we use the ordinary bowel grasper. Be careful, this fat you must inspect, lower down. Alignment of the colon. Virtually tension free, there's no bowstring, alignment is correct. Thank you.
Thank you.
No drains, just single shot of antibiotics. Yes, thank you.
Yeah, thank you, Dr. Roy. It was a very clean, meticulous dissection of the sigmoid. I'll just set the ball rolling. I thought you said that if it were a rectal cancer, you would have gone higher on the inferior jugular vein.
IMV, yes,
and in a sigmoid cancer, you wouldn't go that high.
Not really.
Any reason for that?
I mean, we don't need so much of bowel,
the lengthening of the bowel to reduce tension, you mean?
If you go up to the pancreatic inferior border and take the IMV, you get an additional 6 centimeter of the colonic lengthening, which is sort of mandatory for a LAR. But for a sigmoid, we don't need, because we don't remove the entire sigmoid, just a proximal 5 to 10 centimeter according to Japanese or the ESMO guidelines is enough.
So for the extra length, you would go higher?
For a LAR, yes.
Thank you. Any question, any comments?
So when you go for a height tile,
yes,
for a left colon lesion, descending colon, how far the lateral rectal artery you can depend on? The whole of the left colon will be supplied by the lateral rectal artery?
So for a left colectomy, I don't remember when did I last do a last left hemicolectomy, you see. This hemicolectomy is a very textbook term. If you believe the Japanese, what you need to do is to identify the basically central vascular ligation. So for a mid-colon tumor, left colic artery and perhaps the left branch of middle colic, and just take 5 centimeters either side, a sort of a segmental colectomy, which is what I do.
Yeah, but
if you have to ligate the IMA, so you have to sacrifice the sigmoid. The inferior rectal artery doesn't go beyond the rectosigmoid junction. So if by any reason you have to ligate the IMA, the sigmoid has to be sacrificed.
Yeah, probably a bit above the rectal sigmoid junction also you may be able to do it. The whole sigmoid probably may not need to be. You can go for a high anastomosis as well.
Yeah, but if you take the IMA, the rectal stump is being supplied by the inferior rectal. The middle rectal for all practice doesn't exist. So the question is, how far high up does the inferior rectal artery anastomose? The Japanese have shown that it is the last 6 centimeter of the sigmoid, the entire rectum, and the distal 6 centimeter of the sigmoid can be supplied by the inferior rectum. But don't take a chance.
Yeah, that's what.
Anyone else from the audience?
I would add on to that.
Sure.
So, shouldn't you be ligating the IMA distal to the origin of superior rectal artery, sir, in such a case?
You mean low tie?
For sigmoid colectomy, do you actually need to?
Yes, sir. See, this particular, I'm pleased that you brought out this controversy. It's actually controversial. The Japanese recently finished a big RCT, right? And it was sort of a post hoc analysis, post hoc. High tie versus low tie for a sigmoid, there's no difference. The complications are more if you do a high tie. I take your point.
Per rectum will be supplied by the superior rectal. If you take that supply, then there can be ischemia and an osmotic leak can occur. Sir.
I take your point, yeah.
Thank you, Dr. Roy.
Thank you.